So now that we've talked about the evidence, and we've already talked a fair amount, obviously, about how it might apply to clinical practice, we're going to do that again. And we're also going to talk more about how health plans build coverage policies for new drugs and how this kind of evidence and this kind of context will be viewed in kind of health plans and insurers as how they do their policy. We'll talk about future research and some aspects about pricing as well. So that's what we're going to do for about an hour. So it's going to be quick. We've got a lot of great people at the table. You all know our clinical expert and patient experts. So let's just have the folks who have joined the table introduce themselves, please. Your name and conflicts are up there, but please introduce yourself, and we'll get started after that. Bernie, go ahead.
Hi, Bernie Good. I'm a senior medical director at UPMC Health Plan, where I direct a center for value-based pharmacy initiatives. So I am here on behalf of UPMC Health Plan, but I have also been given permission to represent VA from VA Central Office. So I spent much of my career as the chairperson of the Medical Advisory Panel for Pharmacy Benefits Management, and we basically did formulary management and looking at new drugs and how to utilize them within our system.
So Bernie, you and I were talking before. Although you're not the official ambassador of the VA to this meeting, you're serving as its personal emissary to do their work, right?
I'm still involved. I retired from the VA, but I do work as a volunteer there. Still see patients and still am involved with the medical advisory.
Great, thank you, Kayla.
Hi, good afternoon. I'm Kayla Weiser. I'm located here in St. Louis. I'm here on behalf of Anthem or Ingenio RX, the PBM. I am a clinical pharmacist, have no conflicts of interest to disclose.
Great. And Craig?
I'm Craig Granowitz. I'm the Chief Medical Officer at Ameren. My conflict is I'm a full-time employee of Ameren.
Thank you for being here with us. We really appreciate it. Okay, let's start with the patients again. So you've heard the discussion, you've seen the votes. Now we're going to talk more about what really happens on the ground. And you mentioned shared decision making before. It's come up in a variety of different ways. I'll ask you at the very end, too, kind of what's the one theme that you want people to remember from this meeting? What's the one major lesson? But what would you set for us as the beginning point for our discussion now as we do talk about how this evidence will be looked at by payers and others to create coverage policies, and also discussions around price negotiations and that kind of thing. What's the most important thing for us to make sure we talk about from the patient perspective? All right?
I think one thing to consider is that when you're in a doctor's office or in a hospital, you are talking to your professional, and I know just from personal experience, all of a sudden the world stops. You know, the doctor's telling you A, B, C, and you're thinking, well, wait a minute, let's just start back at the beginning again. So I think that as a doctor to express, you know, not just say, oh, you need to do this, this, and this, but really be able to communicate with the patient and the caregiver all the facts that you are aware of, and give them time to digest it, because I frankly think that the days are gone that you walk in and the doctor says, let's do this, this, and this, and you say, sure, no problem, and you go ahead. And I think that as patients, we have to be very alert and aware of what is this drug, how does it interact with my other medicines I'm taking?
Right.
I just think that when you're talking to a patient, you get them at a very intense moment. And I think that that's really important to remember.
Andrea?
I would just like to add two things. First, the innovations in medicine are exciting and amazing, except for if you can't access it, then it does you no good. And so I think that that's really important in the development of everything that we're doing, because if we can't get it to the patients who need it and they can afford it, then it's really doing us no good. The second thing that I would like to add is that not only do we need to give them more explanation, but they need to understand what this medication is doing and what it's for, because we have a lot of patients who come to us and say, well, I'm on this drug, I don't know what it does, but I was told to take it, so I just take it. And so that may be also a big problem with medication adherence and switching out medications for each other because they're not really understanding why they're taking it.
Yeah. Thank you. And if I can build on that too, I think, and maybe this is probably from my perspective of having been a primary care doctor, I had the frequent experience of patients coming home from the hospital after a heart attack or something else, and they would have their fistful of new drugs.
Yeah.
And they would not even know what they were for. They wouldn't know. They were just going to take them. But now we're going to have one or two more to throw into the mix, and I just know that I think the whole system should view this as a challenge to maybe really take seriously the informational overload and other kinds of challenges that patients and families face, and doctors too. And how are we going to help everybody figure out what to do with an increasing set of drugs, each of which in its own little world has been shown to be effective, but combined, it's very hard sometimes for patients and families.
And when do you take them? Do you take them with food? Do you take
all the real questions that come up?
All the particulars that when you're being checked out of the hospital, you don't have the presence of mind to be able to understand what they're telling you.
Yeah. Jeremy, you wanted to add?
Relatedly, though now might not be the time, what we have not talked about at all today is PCSK9s and SGLT2s, which are competing drugs and add to both the complication and cost quite dramatically. The PCSK9s, obviously, ICER's played a big role with, but essentially have the same benefit and 3 times the cost. The SGLT2s you're going to be discussing soon have, in some ways, a similar or a larger benefit, the same cost, but also have very, very overlapping potential patient populations, making this conversation even more complicated.
Yeah. Jason, I mean, anything
yeah,
about
no,
that?
this is a big issue, and I think I actually have mixed feelings about this. So on one hand, I'm sort of concerned about polypharmacy and people being overwhelmed, and we hear you. I mean, I think when we have these patients first visit after an MI, I'm referencing more the younger patients who maybe thought they were totally healthy, have never been on meds before, and now they're on 4 to 5 things, right? So they're on aspirin, usually another antiplatelet agent, the statin, beta blocker is often an ACE inhibitor, and if they're EF slow, they're often on aldactone. I mean, this is all new. For 6 meds for like a 50-year-old who's never had a problem before is overwhelming. Yeah, excuse me. Yeah, you're 30s. Yeah. So I think it's totally overwhelming. So on one hand, I said maybe we should be judicious about it. On the other hand, I do acknowledge as a cardiologist the strong evidence base behind each one of these things, and I almost wish we could have other systems of care. This is sort of a broader topic, because I can't explain every one of them in a short visit and answer all the questions and making sure, is the statin being taken? Statins are much more effective when taken in the evening, right? That's something you have to say in a visit, but then you have to say about the beta blockers that cause fatigue. It really is difficult. So do we need alternative systems, health coaches, or electronic? Right. So, because that may make the patient experience a lot better, and it may increase adherence to these life-saving medications.
Well, and I think that you also have to look at the
Please make sure you pull that, because I want everybody to hear it. Go ahead.
You also have to look at the emotional side of this, not just the medical side. I think that's one of the things that my cardiologist sort of sat up and took notice, that there was a huge emotional piece to this. I hadn't ever been sick. I hadn't been on medications. And all of a sudden, everything changed. Right. So, I went through a period of time where I was afraid to walk past the front of my house for fear that I was going to get swallowed up in some way because I didn't see my home. And that was, whether it was manufactured or real or whatever, you cannot underestimate the emotional fear that you have when you've been diagnosed with something.
Oh, thank you. So, in some ways, this could be the end of our conversation, where we should get back to. And I will come back to talk more about, polypharmacy and some of the choices that will be made. But I think it'd be really healthy for us to send a signal to health systems. This is not the payer so much, but the health system, that the idea of health coaches or some kind of structured decision making is important, has been important, and is only going to get more important as they have more choices, more options. And I sense a real fear, again, maybe this is the old primary care doc in me, of things becoming over-medicalized. If you have 15 minutes or 20 minutes with a patient, and all you're doing is checking on the meds and then it's time to go, when we did, actually this is 20 years ago, we did a project with patients just leaving the hospital after their heart attack. And we talked to them, and their spouses mainly, and we said, what did you not hear about that you needed to know about? And they said all kinds of things that had nothing to do with their medication.
Right.
Can I climb stairs?
Right.
Can I go back to work? Can I have sex again?
Right.
And actually we created a little booklet that encouraged, it was actually called kind of a critical pathway guideline, and on the second visit back it said, for the doctor and patient together had to tick a box saying, discussion about return to sexual practices or function. And we heard later that that was the most successful implementation of any kind of guideline. So today I still think that in my entire life I will probably never create as many QALYs as we did together when we helped patients and their families and their doctors talk about the big picture.
Life.
Right, their life. And that needs to be focused on for every patient, but these patients in particular, the complexity of their lives.
Right. Well, research shows that patients who are supported in a peer fashion do better. They have lower readmission rates. They adhere to their medication better. They have better long-term outcomes. And the reason is exactly what you're saying, is that they get the answers to these questions too busy to be able to answer, or really can't answer because they aren't living it. It's one thing to give somebody a paper with guidelines to say this is what you should do.
Right.
But to
You need
put that
support.
into practice in actual real world doesn't always translate. I know that I should not feed my children fast food. I mean, right? I should not feed them that. But as a working mom, and it's 5 o'clock, I get off work and have to be at the dance studio at 5:30, and I have 3 hungry kids to feed.
Right.
The Chick-fil-A drive-thru looks really good. So that's the information we need to be giving patients, more than just this statin will do this for you or this will do that for you.
Right. All right, thanks. Okay, I am going to be sensitive to the time, and I want to try to march through issues around rivaroxaban and then turn to Vascepa, and we'll try to wrap it all back up together. So a few of the things that I think stand out in the thinking about how this information will be translated into coverage policy, at least, is in some specific areas, and one of which is the kind of post-MI, DAPT versus something else world. So again, from your perspective, having, again, heard the evidence again today, been part of the discussion, how do you think clinicians and payers, if in any way payers have a role to play here, what is the thinking that's going to go into what happens after patients have an MI? What is covered, what isn't covered? Is it going to be completely, should it be left up to the clinician? Are there some structures to the decision making that need to go into that particular situation? Jason, what do you think?
Yeah, I mean, I guess what I would say is that in standard cardiology practice, and I'm saying this anecdotally, but this has been validated in papers from registries, and real-world registries in particular, is that the standard option after myocardial infarction for people who, for whatever reason, we deem at higher risk of recurrent thrombotic events, so like worried they're going to have a heart attack, and an acceptable or lower risk of bleeding, is prolonged dual antiplatelet therapy. We can debate about the evidence for that. A lot of that comes out of the dual antiplatelet trial, which was this 12 months versus 30 months. Truly, that was all stented patients. A lot of them did have MIs, but not all of them. So there's issues around patient population. But that is the practice now. So there is a yawning gap in comparative clinical effectiveness. And the session today did a great job of showing this about the role of rivaroxaban low dose as a substitute for dual antiplatelet therapy in these patients. There is no clear answer for us as clinicians, and as such, I think a lot of us use DAPT in these circumstances. So I suspect that until that question is evaluated through either observational research or hopefully a clinical trial, I don't see a big role for low-dose rivaroxaban in secondary prevention of MI.
And that's
I'm not saying that
because
should be or shouldn't be. It's just there's not adequate evidence, and then there's
That it's better than DAPT, you mean?
Yeah, I mean.
So why not use it anyway?
Say it again.
If you think it works, if the indication covers that population anyway, why stick with DAPT?
Yeah, I'm convinced of the comparative clinical effectiveness of low-dose rivaroxaban and low-dose aspirin against low-dose aspirin alone, but I have no real rigorous knowledge of the comparison between DAPT and aspirin rivaroxaban.
Right.
I don't have a good way to adjudicate that. And then I personally am a little uneasy in a sense that I interpret the trial results in part about, I do think it's an important trial result. It's a reminder that these patients are also at risk of stroke, but that the endpoint is a joint endpoint, and so much of that was driven by stroke in these patients. So that's enough for me to keep most of these patients on DAPT, although I would love, and my colleagues would love, to know a head-to-head comparison of these two treatment regimens. I think that would, until that occurs, if it occurs, I think the role for low-dose rivaroxaban will be limited in real-world clinical practice.
Okay. Jeremy, you may want to kick in too, but even before you do, let me quickly ask the payers. Is this a space that payers would ever get involved in? Do you think payers would ever try to pick a favorite in a particular niche like this and say, we want you clinicians to do DAPT, or we want you to use Xarelto? What would they ever get in that?
I don't know that either of the systems that I've worked in have specifically addressed this, but what I seem to think will happen is patients get their stent. They get 12 months of dual antiplatelet therapies, and at that point, they're still deemed as, they still got that stent in, they're still very high risk patients. Some of them may continue to have some of these high risk features that got them there in the first place. I see those patients transitioning to low-dose rivaroxaban because a lot of people will just stop those drugs anyway. There are some health systems that say stop dual antiplatelet therapy at 12 months. And so I think, a logical thing might be to then at that point to switch them. Whether that's better than continuing on them dual antiplatelet therapy or starting off with Riva, I don't know, but I think at least now, most patients are going to get dual antiplatelet therapy after a procedure or after, an admission for myocardial infarction.
Doesn't it seem like it'd be a great opportunity for a PCORI study?
Yeah.
After 12 months of DAPT, randomize them to continue DAPT or Xarelto?
Yeah, or the other way, for sure, yes, that'd be so informative. And then also where you could randomize people at 30 months, right? Okay. 2.5 years, referencing the end of the DAPT trial. I think either would be very helpful.
Okay. So let's talk more then about rivaroxaban and its potential coverage and how the evidence will be interpreted. We happen to notice that in the UK, NICE, when it created its guideline around this area, it really used the COMPASS eligibility criteria to, if you will, to keep things quite narrow. So they require that patients, actually I think we had it up here, since I knew I wouldn't remember it. Okay, age 65 or over, atherosclerosis in at least 2 vascular territories. So you had to have 2 vascular territories, or 2 or more of the following risk factors: current smoking, diabetes, kidney dysfunction, heart failure, ischemic stroke. Now we're up to about, 80% of the population, it seems like. So I'm not sure if that does feel more narrow than the label in the US, which is basically chronic CVD or PAD. How do you guys think on the coverage side of things? This is a perennial issue that we come up against in our meetings. There's the evidence from the clinical trial, sometimes just one, which has very specific eligibility criteria: age, risk, comorbidities, in or out. And then you get an FDA label that may use broader language, either all patients, or it just may kind of ignore some of these kind of eligibility criteria. And so payers sometimes are looking at this and they wonder, should we use the clinical criteria used for eligibility to make sure that we're getting the right patients treated for a variety of reasons? What do you think is happening inside health plans now? Do they just cut and paste the FDA label and they're not trying to get more specific around it? Or are they going to do what NICE did and get into the weeds a bit on some of these clinical criteria.
So the VA will take, will look at the clinical trials and try to figure out which are the patients that benefited. Typically, they will use the inclusion and exclusion criteria of the clinical trial, unless there's something really glaring. There are certain patients that did poorly despite the inclusion criteria or exclusion, and so sometimes they will add those on. In the case of the commercial health plan, so I should just give a brief thing. UPMC health plan is about half the size of the VA in terms of the number of covered lives. It's a large health plan, regional health plan in Pennsylvania, covers most of the state. And it has lots of different lines of business, commercial, Medicare, Medicaid, SNP, CHIP, all that. So anyway, they tend to follow the FDA labeled indications pretty clearly and then rely on things like tiered co-pays and things like that to sort of, as well as prior authorization, but pretty much usually limited to the indication. I think the key to any payer is to say, to look at their patient population. If you look at the VA, the numbers of patients potentially eligible for rivaroxaban, it's a lot more. You all, in your budget analysis, I think said 6.7% of the patients would be eligible for it. It's a lot higher in the VA. And what that number is, we haven't modeled that, but I looked at some modeling for the PCSK9s, and it looked to be about 650,000 patients would be good candidates for PCSK9, and you could use that sort of as a surrogate. That's a lot of patients potentially that could get it. And so I think the key is for all of these systems, you don't want to set things up so that patients who should get a medication can't have access, but you really want to try to make sure that patients that are not likely to benefit, or even worse, experience harm, don't get them. One of the things that the health plan I'm with now, UPMC, is what they try to do just with these medications in general is, if we make a commitment to that medication, to get to some of these points here, they develop wraparound programs to try to make sure that if we're going to make a commitment to this patient and with this medication that we think have some risks as well as lots of benefits, we want to make sure that give the patient the best chance to make sure it works. So we have clinical pharmacists that are calling to make sure the patients are doing the right thing, that they understand if they have questions about it, because so often, first of all, patients don't fill medications. We think they're taking them, they're not even taking them, and obviously the best medication in the world doesn't work if it's not taken.
Yeah. That was one of my least favorite things I like to hear as a primary care doc. They'd bring all their medications and they said, I decided not to take any of them before I talked to you first. Yeah, right. Like, oh, this is not what you wanted to hear.
Yeah.
At least you're here today and we can get you started now. Kayla, not to put you on the spot, but to put you on the spot. So have you looked at your current coverage policy for rivaroxaban? Do you know what it is? I'm just kind of curious if you, or maybe Bernie, have you guys done any use of have you made any use of the clinical criteria for eligibility in your design of your coverage policy, or not? Do you know?
Well, I can't speak to the specific Xarelto criteria, but I do know as a whole at IngenioRx, and I apologize, I misspoke earlier about conflict of interest. I am a full-time employee at IngenioRx. We do look at not only FDA label, but also clinical trial inclusion criteria. So yes, we do look at that to guide therapy to patients where there is clear evidence of clinical benefit.
And you don't know in this particular case, I know you have different criteria sometimes for different employers, but do you know any particular criteria that you do or don't have? I mean, I know some of your coverage is available online, so it's not all confidential. Do you happen to know if you've used it? Bernie, did you look before you came? So let me pitch it to Bernie. What do you guys do?
It pretty much follows the clinical trial data. So exclusion is patients with high-risk bleeding, ejection fraction less than 40%, inclusion, myocardial infarction in the past 20 years, or high risk, which is one of, you have to have two, so diabetes or stable angina, diabetes smoker, over the age of 65, peripheral artery disease with low ABI.
Right.
With the health plan in the commercial space, they basically just have prior auth for the FDA labeled indication. In the Medicare space, it's on the formulary, period.
On the VA.
No, this was, so
Oh,
at UPMC
Medicare.
in the Medicare
Got it.
line of business, it's just on the formulary.
formulary,
It's
right.
one of the preferred drugs.
Right.
In their commercial line of business, it's prior auth based on the FDA indication.
So back to the clinical experts and clinicians also. So this is nothing new to you. Some health plans, some of your patients will be covered in a way that it's basically just you write it, we cover it. Others, you'll have to tick a lot of boxes. There's a prior auth form. It might get rejected the first time around. It might not. But do you have any guidance for us on how you think the evidence as it exists and the trial eligibility criteria should or should not be translated into a coverage policy in this situation?
That's perfect for you.
Jeremy, I'll get you one of these times.
I think that, I guess I'll say a couple things. So I've already referenced that the PI on the CEPAC trials gave grand rounds last week at my institution, and the nurse that I work with, I mean, I'm not making this up, texted me, she used my cell phone, during the talk saying, can you raise your hand, Jason, and tell them that none of us do it because of the prior auth? Yeah, this is the nurse that has to process the prior auth. So I think the current state, at least for the CEP, this is maybe we talk about rivaroxaban is a little bit of a different issue, is that it's relatively difficult to get coverage no matter the clinical scenario. I think, as you have deliberated and thought, that in the conditions aligned with the trial, that it's a relatively there's relatively compelling evidence of clinical efficacy. I think that if there's and we do this a lot, is that I think where it's going to get more controversial is that I think if you believe in the comparative clinical evidence presented here, it's likely to be clinically effective in other situations as well when people have high risk. And that's where I think it would be more controversial, especially at a high price. But whether cost effective or not at a relatively high price. So I think that it's also very difficult in frontline clinical medicine to sort of remember, is the EF 40 or is it 45 kind of thing. So while I totally understand why one would create coverage guidelines around the clinical trial inclusion criteria, I wouldn't criticize that at all. As a frontline clinical person, it is challenging sometimes to know. Not sure there's an easy way around it, because there are legitimate issues, and you guys have spoken very eloquently about this today, about creeping of indications to older patients that may be hurt, or people at higher risk of bleeding, for example, with the anticoagulants. With rivaroxaban, I think what's confusing is rivaroxaban, the barriers to utilization for things like atrial fibrillation or venous thrombosis are actually relatively, practically we don't find it much of a problem. I don't know as much about the dose, that if there's situations where there's specific coverage decisions around the different dose, because this is a different dose than we would use for those other indications.
So maybe because rivaroxaban and the other DOACs have been around longer, you kind of went through you went through some phase in which the prior
right, it was much harder.
Higher,
yeah,
and
for
now,
sure.
in the sense they've been out there longer.
For sure.
And I mean, any drug like this that has known risks, the bleeding, I think there's more rationale. Certainly if you hear from payers, they will say there's more rationale for our prior auth, because we're really trying to make sure that if we're going to take that risk,
for sure,
we're in a patient population that we think really will benefit.
For sure.
So that's part of the rationale. Jeremy, did you want to?
I mean, we haven't spoken much about the weird thing with FDA coming up in November, where
with VASCEPA, you mean?
Yeah,
we're coming to VASCEPA.
Okay.
We will get there.
All right, so all
right, one more question then for clinical experts on this. So, and I'm thinking back again to enalapril, captopril, remember, decades ago? So the first one that gets approved for an indication, then the second one comes through and it has a slightly different indication. People start to wonder, it's the same type of medication, same general class, is there a class effect? So here, let's just imagine a payer has a favorite DOAC and it's not, Xarelto, it's not rivaroxaban, it's something else. Or the patient just is on it for AFib or whatever else, is on a different DOAC.
Yeah.
Now there's a cardiac indication, if you will, or maybe there always was, the same risk factors. Anyway, do you think cardiologists will feel that this is a class effect, or do you think oops, I'm going to have to take them off of their other DOAC and put them on rivaroxaban, given the new evidence I'm seeing.
Yeah.
What's the pattern of thinking going to be?
I think the dose is very different. I mean, the difference between 20 milligrams once daily and 2.5 milligrams twice daily is dramatic enough that I would be surprised if people were to flip. And since those very low doses of the other drugs don't even exist, it's not, as of what we have right now, it's not clear to me how you'd even do that.
Except Pixaban has been studied at a lower dose and was not as effective. Yeah. And so we have evidence that we shouldn't assume that there's a class effect. Right. And that would be risky to make that assumption.
Yeah, and I think most of my colleagues would agree with that. I think, especially, so the basic thinking about prevention of MI is that in general this is a platelet thing, right? So I think to have a factor Xa inhibitor as a role, I think it's a little bit, I'm not speaking normatively about the data. The data are what we've talked about all day, but I think that it's a different concept. It's mechanistically a different concept. So I think a lot of us would be really reluctant to take that 2 steps further and sort of extend that to other DOACs.
Well, there's also evidence with dabigatran, Pradaxa, that physicians were underdosing it, and that was real-world evidence looking at. It was David Graham from the FDA, his group that did the study, but using Medicare data. And outcomes were significantly worse when the physicians thought, let's drop the dose, although it wasn't evidence-based. So I think I agree with Jeremy. The doses are so radically different. I can't imagine someone doing that. If they have an indication for apixaban, they're probably going to stay on apixaban, and whether or not they're getting that benefit, who knows, but they're going to be left on. Like if it's for atrial fibrillation or something, I don't see them dropping down to like 2.5 for the cardiovascular.
No, exactly. And I'll also just add that, the issue of triple therapy when people are at high risk, recent stent or high risk of coronary thrombosis and atrial fibrillation is another very difficult topic that I won't delve into, but I think that the one thing we've learned from these clinical trials is that in any case when you have people on 3 blood thinners, I know the dose is a different factor here. 3 blood thinners, you bleed a lot more than 2 blood thinners, in general. So I think one of the things, I know the dose reduction throws a bit of a wrench into that, but what I would say about that is that if someone was on the full dose of rivaroxaban or apixaban or DABI or something else like that, most of us, when I come back to that conceptual model where we weigh thrombosis and bleeding, again, that's like the basic tools of our trade in outpatient, stable clinical cardiology, most of us just say, let's not do it. Let's not do it. We get that there's slightly higher risk of thrombosis, but we think of, in general, on 3 agents as the risk of bleeding is so much higher. And there are multiple clinical trials that have demonstrated that at this point. We just say, this is not the patient I'm going to weigh the risks of bleeding and thrombosis because the risk of bleeding will be almost always higher in any patient, despite even higher risk of thrombosis.
Sort of relatedly, I do think there's going to be a indication creep wall for rivaroxaban that doesn't exist for a lot of other drugs, which is that I just can't imagine people using it for primary prevention, even high-risk primary prevention, just as the nature of the anticoagulant, whereas something like Vascepa, I could imagine anyone with high trigs being given it the same way we saw indication creep for so many other preventative medicines. And so I feel like there's at least a little safety there for that particular drug. That might be wrong.
So should we talk indication creep about Vascepa or not? You don't have an indication yet.
You're the moderator.
No, that's true. Thank you for being here. I know it's especially difficult when you don't have your label yet, and there are meetings coming up in November. Actually, one quick question that came up that I just want to make sure we got past. The bleeding outcomes in the research, just in general, the fact that they came up, that these drugs have different ways of kind of measuring the exact same outcome. What would be your recommendation for how we avoid that kind of situation in the future? Should the FDA be held responsible for that? Is it just unavoidable in some circumstances? Because it certainly will confuse the issue for patients and doctors trying to weigh the different relative benefits. So what's your view on that as part of the clinical development program?
Well, there are systems that have been developed, certainly starting in oncology, looking at various classifications of bleeds. I think there's 2 questions you have to ask. The first is the absolute risk and then the relative risk of bleeding, and they're both important questions because what is the background level of bleeding in the group of patients? So for someone who's already anticoagulated, they're going to be at certain higher baseline risk.
So I don't think my question capturing bleed as an outcome, as an adverse event in a trial, was measured differently between the rivaroxaban trial and the VASCEPA trial?
We weren't worrying.
Where'd it go? Or was it versus
I think we mostly were worrying about rivaroxaban versus the DAPT
Sorry,
trials.
I'm
I mean,
sorry, that's where it was.
it's true that in Reduce It, there was a non-significant trend toward higher bleeding, but we weren't very focused on that.
Okay. Because I probably conflated it because we so often find that drugs in the same general clinical area with different companies will come through the FDA with outcomes measuring the same thing, like major bleeds, and measuring it differently, just enough so that it makes it really hard to compare the data. And so just as a general approach to that, do you think that the companies can do something different? Do you think the FDA needs to be held as the kind of gatekeeper here? What do you think would be the best way to have companies coming forward if they were going to try to compare their effectiveness? How would we help them make sure that they use the same outcome measures, measured the same way that you did?
Well, again, I want to reiterate what was already just stated, is that it was not a major issue as part of the Reduce It trial. So I want to be very clear. I'm going to speak in general terms that are not at all related to the clinical trial or have any impact on Reduce It and bleeding. I think what has been established, again, I use oncology and bleeding because I think that's where the most effort has gone over the longest period of time. And there are certain set criteria that have been set by professional organizations regarding classification of bleeding. And I think in general that is negotiated with FDA for a registration trial regarding trial specifics. I think that based on the types of bleeding, organ systems of bleeding, severity of bleeding, certain of these classification systems are better than others. Mm-hmm. So I think a one-size-fits-all approach is probably not going to be the best one because there could be peculiarities of the patient population or the medication that one classification of bleeding might be more appropriate than others.
Andrew, did you have something you wanted to say?
I did, thank you. I think that from a patient perspective, it's really important that I would love to see somebody like the FDA do something that is very, with guidelines around trials, because interpreting data when you're a patient is next to impossible in the best of circumstances. Right. But if you're talking, well, this placebo was made out of this, and this placebo was made out of that, and the outcomes are measured differently depending on the population, severe bleeding versus not severe bleeding, but it's still bleeding. Where is the guideline that gives the exact, so you can compare the outcomes to the exact same comparative line?
Yeah, that was kind of what I was going. So, Craig, I think that in general what you're hearing is that there is an interest in a one-size-fits-all approach because that's what patients and others really need. Otherwise, it's far too easy for it to get confused and for the data to be spun in ways that can just be confusing, I think, to a lot of ears. But let's talk about VASCEPA then. Again, the same issue of applying the clinical trial eligibility to the coverage policy. Bernie, what's going to happen there? For instance, statins. All on a statin. We have to have them all on a statin. There's no FDA label out there. What do you think?
I think the groups that I've been in have struggled with this issue of mineral oil. And, I respect what you said, David, about, that mineral oil has been around. But people were taking mineral oil daily for 5 years or whatever it was. And most people don't take mineral oil. In 30-some years of practice, I never saw a patient who regularly took mineral oil. So we have concerns about that. I hope it's a red herring, but it is just disturbing that in several trials, mineral oil looks like it raises certain lipid fractions in a way that we want, and as well as markers of inflammation. So I think that for that, it makes us heightens our concern for how it's going to be used. The other major concern that we have in terms of using this drug is that where there's, patients, it was studied in patients who were taking statins. And there's a lot of patients that don't like statins. And the results are so impressive that we are concerned that we're expecting that once it gets its indication that it will be promoted as having, legitimately reporting the clinical trial results, which were very impressive. Our concern is that you will then see patients stop taking or their statin compliance will drop. And we're also concerned about, real world, are patients going to take 2 pills twice a day? In the clinical trials, you can, push your patients to take it. So we have a lot of questions, and it's going to be very interesting. I think payers will be very interested in looking to see how this product is being used. Is it being given to statin-intolerant patients to start with? I suspect we will see a fair amount of that. And then will we see statin compliance, medication adherence drop? I suspect that we will. And maybe it's okay. Maybe it works without the statin, but maybe it doesn't. So we have a lot of questions. And we'll just have to see where it goes.
Well, I'll come back and push you a little bit more on the statin issue. I'll ask Kayla too, though. Do you imagine, again, we don't have an FDA approval, don't have a label. Let's just assume it's approved for, prevention of CV events. Given that the trial eligibility required statin use, and a fairly high percent were on, moderate to kind of max statins, how do you think that will be woven into the coverage policy of health plans around the country? Will there be a lot of variability? Will they all say that the patients have to be on a statin before they can get the CEPA? What do you think is going to happen? Not just in Anthem, but kind of across the board.
Yeah, I think this is obviously pending what the FDA decides on for the indication, but we know from the Reduce It trial that all patients were on a statin, and the ICER report mentions we don't know what the evidence is like for patients who didn't take a statin. So that is still insufficient, and we don't know. So our, a coverage policy, which would be evidence-based, would include, the criteria for the patient population in the clinical trial. In that case, so we would ensure statin use and, maybe consider an out for those patients who truly are statin intolerant or contraindicated to therapy.
So the last time I remember hearing this was in the PCSK9 wars, kind of like the Clone Wars. It was an earlier generation, an earlier trilogy, and it was brutal. It was brutal in terms of the variability and how it was kind of adjudicated across different health plans. I'm not picking out any one health plan in particular, but many people heard from doctors and patients that it was sometimes very hard to decide to even know what the health plans meant by kind of moderate or maximal statin therapy. How many months, at what dose? It all had to be documented. If they'd started over, it somehow got kind of lost in the wash. Bernie, first, and then the clinical experts. Do you think we're headed back? I mean, is this going to happen? Basically, a large potential population, much lower priced drug, and we'll come to that. But do you think we'll have statin wars over this in terms of interpretation of what is or isn't statin use that would be required?
I think it'll be like the PCSK9. So I think most prior authorizations, or like in VA, criteria for use, say that the patient should be on a statin. But if you look at actual utilization, in the VA, outside of the VA, most patients there's more patients who are not on a statin that get a PCSK9 than are on a statin. So obviously, there's been a lot of adjudications, and patients are given access who can't take a statin. I suspect we'll see some of the same thing with the CEPA. I mean, I think that, physicians are legitimately concerned about these patients who will not take a statin. Come hell or high water, they're not going to take a statin. And they need, I think, don't just stand there, do something. You need to do something. And so I suspect that, and I'm not blaming them, I'd probably be in the same situation, perhaps with some patients. So I think you'll see it, but we'll have to be seen. The interest has not been as high for this drug yet, but I think it's because it doesn't have an indication yet. There aren't people clamoring for it for triglycerides above 500 right now, but we'll see once it gets, and I'm sure it'll get that indication.
Craig, what's the experience been of your company? I'm sure you get your own view of, and this is with the previous indication and the way that it's been adjudicated. Do you think it's been any lessons learned, I guess, in terms of how you feel prior auth has been done well or inappropriately with the previous indication that should help guide us for the future one?
I think they're very different uses, and I'm not sure they're actually, one is very informative for the other. One I would consider an orphan use, really, the group of patients that have triglycerides above 500, thankfully, is a relatively small group. The use we're talking about here is a far wider number of patients. I do want to make one comment, though, about substitution of therapy. That's certainly not something that is scientifically plausible, nor studied, nor something that we as a company have talked about or encouraged in any way. We believe that there are different mechanisms to lower LDL, and that is one domain of risk. And we believe that a patient with a high baseline triglyceride has a different, separate risk profile. And we have no data one way or the other to substitute a patient to be treated with Vascepa who has high triglycerides who's not on a statin. So I really can't even comment, and I don't think any of the medical experts involved have ever really talked about that as a substitution, because we don't really see it that way. So I think that we look at LDL management as a discrete clinical challenge, and there are a number of different options for that, and there are potentially more options that are coming over the next year or two depending upon their regulatory status. And then we believe that this high triglyceride patient on a statin with well-controlled LDL still represents significant risk. And I think one of the most important aspects in the REDUCE-IT study is that the placebo group had an event rate of 28.5% over 4.9 years. So these are patients with a baseline LDL of 74 and on all the medications for all these other risk factors in the context of a clinical trial, so they're most likely taking it. So this represents a significant group of residual risk that is persistent beyond the standard conditions, including having an LDL that is at least 30 milligrams per deciliter below the U.S. average.
Clinical experts, what are we going to do with statins and
I think
what are payers going to do?
There's so many interesting points to respond to. I guess I'll start by saying, statins are foundational in coronary disease. They're very effective. They actually are more tolerated than I think is recognized. I think, as we all would agree, I would bemoan if one of the effects of the CEPA's availability was to have people say, I don't want to take a statin because I have this other option, because that's not an evidence-based statement. But this is one thing, I do research and I take care of patients. When I'm in the clinic, I don't have every option available. So commonly, people come to me and say, I don't want to take a statin. I know you don't think it causes memory loss or muscle aches or all the things, but I'm just not taking it. So I would be concerned about a coverage policy that demands. So while I insist on the foundational nature of statins for the treatment of this condition, I also would bemoan coverage policies that didn't allow Vascepa to be used if a statin was not being used. And the reason is because, not because I think that's an appropriate substitution, it is not an appropriate or evidence-based substitution, but in the patient that won't take or can't tolerate statin, really can't tolerate, and this is where this also is tricky.
Now, let me just drive a truck
Please,
through that.
go ahead.
Okay? Won't take or can't tolerate.
Right.
In payer land are completely different lines of prior auth.
It's almost saying no.
What's that?
It's a patient, you mark off a box. It's hard to, if you can't tell the difference, you can't tell it's not clear now. Certainly as providers, we're all used to the patient saying, I get muscle aches every time, and then you check off he gets muscle aches. And to be honest, 90% of the time, I can't tell the difference between won't take and won't tolerate if they're telling me I get muscle aches. That's certainly gamesmanship we all, it's hard to not engage in. Right. So.
We met with clinical experts at, I guess it was the second PCSK9 meeting, and one of them had a referral practice for statin-intolerant patients, and he got them all on statins.
Yeah, I remember this story. Yeah.
He said those cardiologists just don't know how to do it.
Yeah. No, sure. No, and I was at that session, it was 4.5 years ago, and I remember Dr. Thompson saying that, and I think that is also true. It is, I think the payers could come back to me, and it's like sort of fair to say, Jason, look, if you just sit down with them longer and really explain the evidence base and follow up by phone and make sure that the muscle aches, there's a lot of fear and sort of, and fear is legitimate. Maybe if we had better systems of care, or if I was able to see them more in the office, I could convince them to take the statins. My view is nuance. I will say, as a doctor, like, it is going to be frustrating. If I've really done my due diligence here, they really won't take the statin, and then the Vascepa we can't get because of a prior auth.
Right.
Like, I will say that's going to.
And I know patients are going to agree with you. Let me ask one more quick prior auth question, because it will be another real one. The eligibility criteria of 135 and above for the triglycerides, the evidence that you saw stratified that suggested maybe it does, maybe it doesn't have some correlation with the effectiveness. Health plans will see that in the eligibility criteria, and my guess is that many will put it into the coverage criteria. Do you think clinically that makes sense? Do you think that you will want to use it for patients who have a triglyceride of 100, 110?
I think that the question of the comparative clinical effectiveness of Vascepa versus no Vascepa in a statin-treated patient who's had an MI, for example, and the triglycerides are 110 or 120 is largely unknown. But based on the arguments that we've gone through today about the biology of it, namely that it could be an EPA direct effect and there was those 4 lines, right? There was no differences in the different triglyceride categories. I'm speculating, all sorts of thin ice right now, but I think it's reasonable to speculate that the drug is effective in the lower triglyceride groups. And I don't know that we know the answer. We don't know the real answer to this LDL either. So I said this on the call once. It's reasonable to think about coronary disease also in sort of minimizing risks in categories. So there's lipid risk, there's like inflammation risk, which is sort of conceptual. Canakinumab, doesn't have an FDA label for this, but at least we think about reducing inflammation as a mechanism of improving outcomes. And then we think about blood thinners. So 2 of the 3 have been discussed today. I think it's reasonable to assume that we don't know the lower limit of an optimal triglycerides in the same way that we don't know the lower limit for the optimal LDL lower. So I'm not saying there's evidence behind what I'm saying, but it's reasonable to speculate that such an effect is also true at that lower level of triglycerides.
Jeremy, anything?
Yeah, I mean, if I were a betting man, I would bet that trial would be positive also, and that the triglycerides, which may or may not be the mechanism, probably don't matter, which is what we found with statins. For a long time, we assumed they only worked in high LDL, and consistently we kept finding lower was safer, and these are drugs that prevent events. But that trial has not been done, and we have absolutely no reason to look one way or another about it. And 150 is pretty low. So will people be giving this drug in a trig of 100? I can't guess the future in that way. Again, it wouldn't be my first drug to go for under those circumstances. I had hoped to see the trial someday. That would be interesting.
Payers, the way the world works, every once in a while when there's a new drug and a pent-up interest in it, they have a hard time feeling like they are going to be the easiest insurer on the block because they'll get too much adverse selection. Does that mean that it's more likely in this kind of situation that they would use the 135 as a cutoff to try to maintain a tighter, if you will, prior auth compared to other plans? Because you've just heard that there's kind of, clinicians are kind of swimming around this idea. They know there's no evidence, but they don't see any reason that it shouldn't work. How does a payer hear that and translate it into coverage policy?
So we don't know what the label is going to say.
Right.
But if the label says in patients with a triglyceride, fasting triglyceride greater than 135, I think most payers will say, in patients with a fasting triglyceride greater than 135. Prior authorizations can be, in most health systems, I think can be appealed. Now, I know it's a pain in the neck, but I just don't think that anyone's going to not follow, go beyond the label, especially when there's no evidence. It'd be one thing if the label says 135, but there's some additional evidence that shows that, it works regardless of what the triglyceride is, even when triglycerides are low. So I think, as a payer, you have to have something to hang your hat on, and I think it will be the labeled indication or what the clinical trial chose to use.
Well, you said
both.
or, so let's just hypothetically, the FDA doesn't mention triglycerides in its label. Clinical trial required 135 up. Does that 135 go into the prior auth?
So neither system has done it, but my guess would be you'll see it in the VA criteria for use, and you won't see it in the commercial plan. The commercial plan will follow the FDA,
the broader label,
indicate what the label says.
Okay. Well, thank you for being that clear about it, because I think that is part of the variation that patients and doctors know is out there, and it's hard sometimes to understand where it comes from. But I think today's been a great example of how it's not always so black and white. I mean, we've talked before about there should be some pathophysiological story around why you would need, if you will, an eligibility criteria baked into your prior auth, but it's not always black and white.
To be clear, though, I think that's not going to make that much of a difference. I think if, let's say, it was half of the patients, had fasting triglycerides lower than that, and I don't know what it'll be, but it's not half. Maybe other health plans would say, look, even though the FDA was very generous in their label, we're going to stick to the clinical trial. I think it's more of a practical thing in that case. I just don't think you're going to have that many patients.
Okay, thanks. We're into the home stretch. I'm going to let you guys start to warm up your final statement. I'm going to ask you, if you would, to have a final kind of what's the most important theme, lesson, action. Sometimes I encourage people to say, what's the request that you would make of somebody else, some other stakeholder, that if they could do that, it would make the world a better place? One sentence, so you get to think about that now. But let's talk about price. Craig, as you heard, 5-digit incremental cost-effectiveness ratios, a price or a cost-effectiveness that makes people happy, high value without even taking a vote. How did that happen coming out of the blocks? Was this something that you guys thought about? Is it just is it a feature of the competitive landscape in cardiology that's different in other areas? And how do you think about the fact that you've had a price for a rare disease, if you will, and now it's going to be for potentially, I think your CEO said 40 million patients. Does the price change when the use goes up by that much of a factor? Should it? Should it come down even, though it's already cost effective? How has your company thought through some of these issues?
I think our CEO has made a number of statements regarding our commitment to responsible pricing and also maintaining access of the product. Contractually also, the product has been available in the marketplace for a number of years, and we are contracted with most of the major payers already, and certainly those contracts have terms and conditions associated with them. But I think there is a strong commitment of the company to make the product as broadly available as possible and to continue to be a partner in our responsible pricing to ensure access to the medication. I don't think we've been unambiguous as a company regarding those values and commitments, and I think our actions have followed the statements that we've been making in that regard.
Do you think the price reflects some psychological feature of it being fish oil and not some fancy, hard to pronounce? I mean, it is hard to pronounce, but it's fish oil. So I've proven that. So, I mean, we try to learn as much as contribute to the dialogue around pricing, and so I think what's the annual net price of the CEPA right now is $1,600 a year? Okay. That's as estimated by SSR Health. Now, to be fair, if you multiply that by, and I'll be completely egregious and take all the patients that your CEO said could benefit and assume that we treat half of them, just half. That's $40 billion a year, each year. If half of the eligible patients that your CEO is targeting take this drug at that price, $40 billion. Is that a price that you think the health system can afford, should afford? Is that something that you guys think about, the budget impact as it gets scaled up?
So again, I can't comment on what number you're referring to in terms of 40 million, what that number is in terms
his
of
quote says, this is your CEO, "We really think we're just getting started, just like statins took a while, but now treat about 40 million patients. There's about an equal number of patients who can potentially benefit from Vascepa."
Yeah, so again, I'm not going to comment specifically on that number per se. I think, as you've already pointed out in your analysis, and I think you made a compelling case, and despite the caveats we had regarding the model, and is it cost effective enough in light of some of these other elements, but by your own analysis, you judged this therapy to be cost effective under 100% of the scenarios that you tested. I think the issue really is one around budget impact is largely going to be outside the realm of what a pharmaceutical company is going to decide, and these are payer decisions and payer contract with their customer decisions, whether that is the government or whether that is a commercial payer with their customers. I think what we've tried to do, and I think your analysis shows, that we have been responsible, that we have generated a product that delivers high efficacy, a good risk benefit, and is cost effective under the scenarios that you tested. I think that is being the responsible player that society expects of the pharmaceutical industry.
Well, it's a much better place to be in, for sure, than arguing about 40 million patients and a drug that's not cost effective, without a doubt. So turning then to the payers, you guys think about cost effectiveness and budget impact sometimes in completely different parts of your organization, even, much less trying to figure out how that should affect the price or the access. What's your view, because we've heard at these kinds of panels before, the general instinct that if a drug is having its indications suddenly expand greatly, that there should be some consideration given to a lower price, but not always. What's your view on how cost effectiveness and budget impact fit together here? And are you worried about half of these patients using it at $40 billion a year for the country?
I would say cost effectiveness doesn't, allow us to open access to all. We still want to guide drug therapy to those patients where there is clinical benefit. So I think ensuring that it's used in those patient populations will, help with the budget impact.
Bernie?
In a system like the VA, it's a fixed budget. And so if the VA spends $150 million a year on Vascepa, we have to. It doesn't just get added to the annual budget. It has to come from something else. Maybe it's a good trade-off, but maybe it's not. And so these are the things that we always struggle with at the VA. When the drugs for hepatitis C came out, it blew up the pharmacy budget, blew it up. But they were so spectacular that what the VA did was just bargained as hard as we could, and it was bare knuckle negotiation. Got the price down, the best price in the among any developed country, far less than Canada, but then treated as many patients as we could, and really pushed it to get it all taken care of. Bit the bullet. It was very difficult, but got over it. The question is this drug or is rivaroxaban, are they in the same category or not? And I think these are the things that we struggle with. I don't sense that we're looking at Vascepa in the VA or at UPMC Health Plan as being a $100 million a year drug. I could be wrong. I'm often wrong. My wife will tell you. But I just don't see it. But I think what will have to happen is if it gets the label and VA all of a sudden sees this huge uptick. I think they're going to need to step back quickly, meet with Amarin and say, what the heck can we do about this? And try to come up with some amicable. I would hope that if being a good partner, if the drug is doing extremely well and you're selling, maybe the price would come down to make it easier. But there's no easy question. Just because a drug is cost effective doesn't mean that it's that's the right thing to do to widely use it. This thing of cost effectiveness, I cut my toes off with my lawnmower a couple of years ago, and I think about this all the time. If I'd have been in the ER and the surgeon comes in and said, hey, good, what's this worth to you? Is this $50,000 for the surgery? Because we'll save your foot. No, I paid $2,000 or something like that for the surgeon, and I can still walk.
You paid $2,000 for a surgeon to fix you? You got a great deal.
Sure. I can't remember. Maybe it was more. I mean, the hospitalization was more, but I think that the surgeon's fee was whatever. You get the point. So anyway, it's tough.
Yeah.
There's so many good drugs that are out there that are cost effective. I mean, we've heard about some of the newer diabetes drugs. There are just so many drugs. And then there's so many other drugs that may or may not be cost effective, but every one of us in this room would want access if we had one of those horrendous diagnoses. If you give any of us metastatic melanoma with brain mets, we all want access to, immunotherapy. So, I mean, it's really tough for pharmacies and for healthcare systems to grapple with these things because nothing happens in a vacuum.
All right, thanks. Real quickly, clinical experts. I came up with this fictitious 50% of the eligible population. Don't try to guess like what health plans will do or anything around prior auth, but just from a pure clinical perspective, what do you think would be the kind of the ideal target for patients to be on these treatments among the eligible populations? And I know they're kind of overlap, but I'm going to try to make you think separately. If you thought of the rivaroxaban eligible population, what percent of them should be on rivaroxaban in 2 to 3 years? Should be.
So, of the people who are eligible as determined by enrollment in these clinical trials?
Oh, well, yes, or by the FDA label, if you will. Yeah. People who you think could benefit should be on the treatment.
Yeah. I'm not sure, to be honest. I think conceptually, and again, I'm extrapolating here, but the patients that I would want these people to get the medicines first, if there was some way to do that, would be those that have residual thrombotic risk. So patients that have, for example, multiple thrombotic myocardial infarctions, the mechanism is related to thrombosis. I think that would be a reasonable first step for.
Give me your ballpark percent estimate.
Yeah. I was trying to avoid it. I think 30 or 40% potentially.
All right, I'll let you off the hook and ask Jeremy about Vasepa.
Vasepa.
Yeah, you get Vasepa.
Yeah, I do think Vasepa is
and
one
there's
where,
no indication yet,
right,
so you get to guess what it will be.
Where the clinical and the policy will be in conflict, because I think you could make an argument that tons of people would benefit a tiny amount, and so.
Right. No, let's assume that it's the clinical trial becomes the FDA label. Eligibility becomes the FDA label. What percent of those patients do you think should be on Vasepa?
Again, what aspect of me do you mean? I think what aspect of me do you mean? Because I do think clinical you could argue that clinically a large number of them probably would have fewer cardiovascular events without major side effects if you did that.
Okay,
with the concern
so
being
the majority. Yeah. Okay. All
No,
right.
that's necessarily
I've run past our appointed hour to start your final statements, but we'll do that rapidly. We will come back, just for our own knowledge, we'll come back and ask Amran offline about the environmental impact of the treatment on fisheries. Apparently this is a significant effect or concern. At least some people are talking about it.
It's pelagic.
So we don't want to overstate it, but we'll just want to know what thinking has gone into the production of the drug itself. Okay, that being said, I would like to start with final statements. One sentence, please, as I mentioned, what you think the most important theme will be. Actually, I think I'll let the patients go last this time because that would give you even more time to think about it. I'll start at that end of the table, please. Craig. That can be a request of other people or one thing that you want to put up on the bulletin board that we don't forget.
The number of cardiovascular deaths due to cardiovascular disease is on the rise. Vasepa represents a new patient dimension and domain that we can modify and reduce cardiovascular morbidity and mortality.
Thank you for being brave. All right, Kayla?
I would say while the trials that we have and spoke about today are very, what's the word I'm looking for? Positive. Mm-hmm. there is a lot of room for more evidence we'd like to see. For example, the CEPA, we want to see what the label is and what the FDA advisory panel talks about at their meeting, as well as for Xarelto, we want to see longer-term data as far as the durability of the efficacy and safety risks involved.
Okay, great, thank you. Bernie?
Interesting studies, interesting meeting. We need post-marketing data in our patient populations to assess for real-world evidence of safety and effectiveness.
You were almost haiku there, and then you blew it. Right? Now I'll go this way. We'll work our way in towards the patients. Jason?
So there's been tremendous progress over decades in the prevention of cardiovascular events, but still a lot of residual risk. And some hypotheses have not turned out well, especially kind of stable coronary disease revascularization as a strategy to prevent cardiovascular events. But the strategy that has been very heartening and effective is medical management. And it's heartening for me to see continued innovation in this space, continued availability of new medicines that still address residual risk in populations that have not had relief from recurrent events. And it's exceptionally heartening for me to see this happen at a price that is well within cost-effectiveness thresholds, which is not something that our committees often see.
Thank you. Jeremy?
While these drugs could have a moderate clinical benefit in quite large population, I think it's most important that not be at the expense of the existing cornerstone drugs.
Brilliant. Maria?
I think the most exciting thing for me is to see it from the research side, and it's encouraging to hear the conversation and the discussion back and forth to try to make the best for the patients.
Thank you. And Andrea?
I think my one sentence would be the best innovation in the world will not help if the patient can't access it.
I'll give that haiku credit, even though it probably formally isn't. That was very good. All right. Well, we could thank you at the end, but since we'll probably be kind of rushing through as we get towards the final comments of the CEPAC, let me just ask them to join me in thanking you for your great participation and insights today. Thank you. All right, CEPAC, please. Oh, we're going to keep going. You don't have to get up. Sit down. You can sit down. You get to listen to them, too. All right, Stuart. Actually, we're a thinned-out group because I know some people had to leave for the airport. But why don't we just go around and you guys get your own final comments, and we'll end up with the chair. Stuart?
Well, there's so many things to comment about. I get to only have one sentence. So I guess I'll go to our patient representatives, since what I do in my everyday work part-time is to coach physicians on how they communicate with patients. So your concern about that in this shared decision-making process resonates with me. So thanks very much.
Thank you. Kurt?
Thank you very much for the informative discussion. As a pharmacist, access to cost-effective and needed medications is a big deal, and so I really appreciate your perspective on that. And I'd also like to reiterate the need for real-world data as we continue to fine-tune our treatment options. Thank you.
Thanks to all members of the panel. I think today we saw, with high certainty, our clinical evidence, we saw high long-term value for money, but then we realized the complexity in the decision-making to implement these therapies, the need for shared decision-making, but it doesn't stop there. The education that's needed in the follow-up, and really the need for team-based care, whether it's patients and physicians, pharmacists, nurses, across the board. So it doesn't stop just with all these different decisions at the payer level and so on.
Great. Thank you, Tim.
Yeah, Scott grabbed a lot of the words I was going to say, but I want to thank ICER and the patients and everybody else who participated with their perspectives. In some ways, this meeting might seem like the most harmonious in terms of our findings, but I want to sort of highlight some levels of uncertainty that we have, and one that I want to point to is I don't think we know enough about the comorbidities that people have with this disease and the polypharmacy issues and the challenges that patients face in that regard, and that was brought up many times. And I think that we need more attention, more research on that, and we definitely need more attention in the spirit of my friend Ryan Barker, who's not here, around the disparity issues, and so I will put in markers on all those fronts. That so I think we need a lot more attention on those issues.
Thanks a lot. Bijan?
Yeah, thank you, ICER, for giving me the opportunity to be here and to be part of this discussion, and also thank all of you. And it's kind of amazing to see the perspective that you have provided, because typically, we do research and it's kind of it gets pigeonholed in things that we do, and then not, getting to know as to what how things are actually happen in real world. And I think that getting that perspective is really important. And I think going back to one thing that I thought we would discuss, one of the things that we have done, for when we evaluate cost effectiveness of certain medications. So in this case, when we are really talking about polypharmacy, I think so the clinicians, you guys really talked about that issue. People might be kind of handed down with 3, 4, 5, 6, whatever number of medications. So I think when we talk about cost effectiveness, I think those you cannot really do cost effectiveness really kind of not taking into consideration other things that patient might be undergoing or patient might to live with. So those aspects should be part of it. I guess in when we really because when you think about it, cost effectiveness of, say, one of the two medications that we talked about, we are really also need to be able to account for the adherence, and the adherence to that medication would probably dependent on what are the other medications that patients are taking. So those are things that probably we can consider as a group at a later point in time. But otherwise, I really appreciate all the insights that you guys all have given. Thank you.
Thank you, Jill.
I don't really have much to add except to say that I agree with you about the need for real-world evidence and the need for more evidence with health disparities. Thank you for your insight and for including me.
So I'm always inspired by the dialogue of these meetings. So it's civil, it's scientific, it's entertaining at times, and I just appreciate everybody's thoughts. The one thing I'll kind of highlight here at the end is that lifestyle management is a foundational part of cardiac risk reduction, and in today's conversation it surfaced maybe once or twice sort of partially, and we're not going to get rid of the residual risk in cardiac care with probably not with another agent, right? That we have to provide peer support, self-management, education support for patients if they're going to be adherent to their plans, if they're going to think about exercise and physical activity and nutrition as foundational lifestyle changes for their risk management. I just want to surface that when you talk about cardiac risk reduction, we need to make sure that we bring forward the importance of what you might call lifestyle management or self-management, education and behavior. Thanks.
Thanks. So just real briefly, not all of our meetings are this chummy. Sometimes some people like these kinds of meetings. Sometimes people feel they're they're boring because no one was throwing thunderbolts at anybody else. But it's part of a larger picture that I think is really important to keep in mind. Not every drug is priced beyond its alignment with the benefit to patients. And for a long time, actually, many of us had heard that innovation in cardiac drugs was a dying business model because everything was generic and it was very hard to show benefit, and it would take thousands of patients and there was no profit there. And then just in the last few years, we've got PCSK9s and other drugs continuing to come. Bempedoic acid is in the pipeline. There are other things. So there's huge innovation coming online. And yes, we're talking about large patient populations, but there's still significant unmet need, as I think the patients and others have spoken to. It always makes me somewhat disheartened that I think of spending in a very cost-effective way to prevent heart attacks, to keep people alive so that they can get cancer or something else around which we will spend amounts on benefits that really don't align very well. So
On that happy note.
there's reason.
Life is still worth it.
There's reason. People sometimes say, "What are you going to do with the money that you would save if you brought the prices down in some of these other areas or some of these particular drugs?" And here's a good example. The system depends for innovation that is incentivized well when people do well with demonstrating their benefits for patients. So we can make handsome rewards available if we are smart with the way that we spend money in other parts, not just in drugs, but across the whole health system. And I think many of you probably heard the news, I guess just yesterday, the Kaiser Family Foundation survey that showed family coverage in this country on the employer side is over $20,000 for the first time, continuing to grow faster than inflation, faster than wages. Where does that end? It ends with hard decisions, trying to do the best we can with resources that are never going to be unlimited. So I applaud the companies and the landscape and everything else that could have contributed to the fact that we have innovation at a cost-effective price. It doesn't mean that we don't think about budget impact and about how we manage the trade-offs that entails. But it's a positive signal that we can have innovation at a fair price. We will get fair access, I'm convinced. And I think that it can serve as an important positive example for other areas of our healthcare system. So that's the lesson I'm taking away from today. Thank you to the great ICER research team and the cost effectiveness team that did such a great job today. Thanks again to our fantastic Policy Roundtable members, and to the CEPAC. Thank you very much again for your diligence and your thoughtful questions and perspectives. Thank you all very much.
Thank you.
I will. I didn't know if